Iontophoresis is the transport of chemicals, specifically ions, across a membrane utilizing continuous monophasic electrical current. Two electrodes are placed on the skin. The active electrode is the one carrying the ions from the medication, so it is very important to know the polarity of the ions. The further the electrodes are placed from one another, the less the superficial density is, therefore decreasing the risk of burns. Distance between the electrodes should be at least the diameter of the electrode. One way to increase ion transfer is by increasing the intensity and duration. Treatment penetrates up to 1.5 centimeters over a 12 to 24 hour period treatment. Treatment duration is typically 10 to 20 minutes in length. Contraindications to iontophoresis include skin sensitivity, sensitivity to aspirin, gastritis or active stomach ulcers, asthma, sensitivity to metals, or sensitivity to seafood. Phonophoresis is a use of therapeutic ultrasound to enhance the delivery of a topical medication into the tissues. It can be done either continuous or pulsed. A continuous wave ultrasound is when a constant ultrasound wave is provided throughout treatment, providing energy the entire time. Pulsed wave ultrasound is when there is an interruption in energy being produced during treatment and no energy is provided. Common medications utilized for phonophoresis are anti-inflammatories or analgesic medications, such as hydrocortisone, lidocaine, or dexamethasone. Parameters for phonophoresis depend on the area being treated and the goals of treatment. To obtain a more superficial tissue penetration, a higher frequency is used, and to obtain a deeper tissue penetration, a lower frequency is used. There are several contraindications to the use of therapeutic ultrasound, which are therefore contraindications to phonophoresis, since therapeutic ultrasound is part of phonophoresis treatment. A few are a known malignancy, a communication barrier, neuropathy, and an active hemorrhage, and heat-sensitive disorders. Precautions include regenerating nerves, spinal cord injury, and fragile skin. Now that you've seen an Achilles tendon rupture and know what iontophoresis is from our lovely intro, let me tell you about treating the Achilles tendon with it. First, I'll share some interesting facts about Achilles tendon ruptures. They are obviously very painful. The most common location for a partial or complete Achilles tendon rupture is in the mid-portion of the tendon, approximately 2 to 6 centimeters from the calcaneal insertion, which is a darn good tidbit to remember. The acute inflammatory phase is thought to last 2 to 7 days after injury. Ruptures are usually caused by acute trauma that suddenly increase stress on the tendon and are unfortunately 5 times more common in men than women. So, as future evidence-based physical therapists, you may be wondering, is iontophoresis even an effective way to treat Achilles tendon ruptures? So I decided to look a bit more into it, and unfortunately, there has been very few studies on this particular topic. However, one study from 2003 did look at treating Achilles tendon pain utilizing iontophoresis with or without the use of dexamethasone. Nieder and colleagues found 25 subjects experiencing acute Achilles tendon pain and randomly assigned them to a group. Each group received 4 20-minute sessions and then a 10-week rehabilitation program. The only difference between the groups was that one group was treated with 3 milliliters of dexamethasone and the other was treated with 3 milliliters of saline solution during iontophoresis therapy. Dexamethasone is a glucocorticoid used to treat inflammation. Iontophoresis parameters were not stated within the paper, which is a tiny bit sketchy. Outcome measures included a questionnaire, toe raise test, range of motion test, and a pain with palpation assessment. The subjects were evaluated at 2 weeks, 6 weeks, 3 months, 6 months, and 1 year after the intervention. There were several significant results determined utilizing a significance of p equals 0.05. The results show that pain during activity was significantly reduced in both groups over time. However, the experimental group experienced a significant decrease in swelling at 3 months. At the 1-year follow-up, a significantly fewer number of subjects in the experimental group reported pain during or after physical activity and had pain during normal walking or when walking up and down stairs compared with before treatment and in comparison with the control group. Overall, larger improvements were seen in the dexamethasone treatment group. However, since both groups were treated with iontophoresis, it cannot be concluded whether the improvements were made from that or due to the natural healing process or to the rehab program. In the end, more research is necessary regarding treatment of acute Achilles tendon pain and iontophoresis.
Today I'm going to be talking about patellar tendinopathy, which is also known as jumper's knee. Patellar tendinitis is an injury to the tendon connecting your kneecap to your shin bone, and it becomes patellar tendinopathy after tendon damage persists for more than a few weeks. Some common causes/risk factors are overuse injury from repeated stress on your patellar tendon, tight quads and hamstrings, and muscular imbalance due to uneven pulling of muscles. Another cause is falling with direct impact to the front of the knee, and is mostly seen in runners and athletes whose sports require jumping, such as basketball and volleyball.
Good job by Bogut overplaying and then Barbosa setting it up, and Andre Iguodala turning back the hands of time.
Some symptoms of patellar tendinopathy are pain below the kneecap, and the pain can worsen with movements that involve extending the knee, such as climbing stairs, squatting, cycling, walking downhill, jumping, and sprinting. Some other symptoms are swelling, stiffness, and inflammation of the tendon, and limitation of certain movements. And there's different grades, and they are as follows. Grade 1 is when pain occurs after an activity without functional impairment. Grade 2 is when there's pain during and after an activity, and their sports performance is still okay. Grade 3 involves prolonged pain during and after activity, with their performance being limited. And grade 4 is pain strongly limits their sports performance and everyday activity.
The study that I looked at was called Wireless versus Wired Iontophoresis for Treating Patellar Tendinopathy, a randomized clinical trial. The study was done by Justin Rigby and colleagues. There were 31 subjects, 22 males and 9 females. Their ages were 24 years old plus or minus 6 years. The intervention included 6 iontophoresis treatment sessions 3 times a week for 2 weeks. There were 3 treatment groups and all the subjects were blinded. Group 1 was the wired dose controller, Group 2 was the wireless patch, and Group 3 was the sham treatment. All treatment groups were instructed to resume daily activity as usual, but Group 2 and Group 3 were instructed to wear their patch for 3 hours after their treatment. The clinician who applied the treatment was semi-blinded due to the setup of the experiment, and the clinician who took measurements was blinded. The outcome measures that were taken were the Kujala anterior knee pain scale, pressure sensitivity, knee extension strength, and a sit-to-stand test.
So I'm going to be talking about some of the results that I found in the paper, and the level of significance was set at p is less than 0.05. Some placebo effects were seen because the sham group showed improvement in pressure sensitivity, and all groups reported an improvement in function based off the AKPS, but the data showed no significant difference. Significant results that were found was that the active treatment groups that used iontophoresis had a decrease in pain during the sit-to-stand test, and although the results are good, more research is needed to prove long-term effects, and there was no follow-up study that was done in this experiment.
Carpal tunnel syndrome is the entrapment of the median nerve in the carpal tunnel, which lies on the ventral aspect of the wrist. The median nerve, along with the flexor muscle tendons, run through the carpal tunnel underneath the transverse carpal ligament. When tissue swelling occurs, it narrows this tunnel and compresses the median nerve, resulting in pain, numbness, tingling, and/or weakness in the distribution of the nerve. This pathology is seen in 3% of all females and 2% of all males. The peak prevalence is seen in females older than 55 years of age. As future evidence-based therapists, it may be helpful to know whether iontophoresis or phonophoresis can be effective forms of treatment for patients dealing with carpal tunnel syndrome. In a study done in 2013 titled Phonophoresis of dexamethasone sodium phosphate may manage pain and symptoms of patients with carpal tunnel syndrome, this question was looked at. This study consisted of 34 patients and 52 hands in total. 18 of these patients had carpal tunnel syndrome in both wrists, while 16 patients had only carpal tunnel syndrome in one wrist. All patients in the study were right hand dominant. These patients were then randomly allocated to two different groups. One group received phonophoresis of 0.4% dexamethasone sodium phosphate, otherwise known as DexP, and the other group received iontophoresis with the same prescription of DexP. The outcome measures assessed included pain assessment by the visual analog scale, electroneurographic measurement to record both motor and sensory latency, and motor and sensory action potential amplitude, and pinch and grip strength. These outcome measures were recorded before treatment began and at the conclusion of treatment at 2 weeks and at a 4-week follow-up. The results of the study showed a significant difference in the phonophoresis group when being compared to the iontophoresis group in the following outcome measures: motor latency, motor action potential amplitude, finger pinch grip strength, hand grip strength, and pain relief. All of these effects were sustained through the follow-up period. What really matters to us as therapists? The clinical bottom line is that when treating carpal tunnel syndrome in patients, phonophoresis may be a more effective treatment than iontophoresis. However, it is important to note that these modalities are rarely, if ever, used as standalone treatments and should rather be used in conjunction with a comprehensive plan of care. Therefore, further research is needed in the area of combination therapy involving ionto or phonophoresis alongside other conservative therapeutic treatments for carpal tunnel syndrome.
So next we will talk about iontophoresis to treat patients with medial or lateral epicondylitis. Lateral epicondylitis, or most commonly known as tennis elbow, is defined as the inflammation of the lateral humeral epicondyle at the origin of the extensor tendons of the forearm. Medial epicondylitis, or golfer's elbow, is also inflammation, but this refers to the medial epicondyle of the humerus at the origin of the flexor tendons of the forearm. These pathologies are caused by forceful, repetitive gripping and lifting over time. It typically occurs in men and women over the age of 40 and affects about 1 to 3% of the U.S. population each year. However, recent studies have shown that the physiological response that occurs in the tendon is not an inflammation process, but rather a degenerative process. So healthcare providers have began the switch to calling this diagnosis epicondylalgia. But for today's purpose, we will call it epicondylitis. So, should we use iontophoresis to treat medial or lateral epicondylitis? After looking at the evidence, again, there were many discrepancies on if it is an effective modality or not. However, I found one study that looked at the effects of iontophoresis using dexamethasone to treat acute medial or lateral epicondylitis. This double-blinded, randomized control trial consisted of 199 subjects between the ages of 18 and 75, all diagnosed with acute epicondylitis. These patients were then randomly assigned to a dexamethasone group or a placebo group. Each group then received 40 milliampere minutes of iontophoresis with either the dexamethasone medication or a saline solution. The main outcome measures taken were the investigator's global evaluation of improvement, the patient's global evaluation of improvement, and the patient's pain on a visual analog scale. So, the investigators evaluated the patients at 2 days and 1 month after their last treatment session. The results after 2 days showed that the patients who received the dexamethasone medication significantly improved in the visual analog scale compared to the placebo group. Also, half of the people in the dexamethasone group received a score of moderate or better in the investigator's global evaluation of improvement compared to only a third of the placebo group. However, there were no significant differences seen at 1 month. The authors think that this could have been due to the fact that the patients were contacted by telephone and not examined by an investigator at 1 month. Lastly, they found that the patients that received the treatment in 10 days or less saw better results than those who received the treatment over a longer span of time. So what is the clinical bottom line? Well, according to this study, iontophoresis may be used in addition to therapy to treat pain in acute medial or lateral epicondylitis, but as like most of these modalities, more research just needs to be done.
Shoulder impingement syndrome, also called swimmer's shoulder or thrower's shoulder, is the most common shoulder complaint in individuals attending orthopedic physical therapy clinics. It involves the tendons of the rotator cuff muscles being impinged in the subacromial space. The main symptom is pain, and in most cases, it is not resolved with oral medication or moderate rest. Exercise is one of the few interventions that have been proven effective in decreasing pain and improving function in patients with shoulder impingement. But what about other interventions like iontophoresis or phonophoresis? A study by Garcia and colleagues compared the effects of phonophoresis and iontophoresis on patients with shoulder impingement syndrome. The study was a double-blind randomized placebo trial. 88 patients diagnosed with shoulder impingement syndrome by a physical medicine specialist participated in the study. Participants were randomly placed into one of the following three groups. One group received standard treatment consisting of supervised exercises and cryotherapy, and placebo iontophoresis and placebo phonophoresis. Another group received standard treatment, iontophoresis, and placebo phonophoresis. The last group received standard treatment, phonophoresis, and placebo iontophoresis. The medication used for both modalities was sodium diclofenac. All participants received 5 daily sessions per week for a total of 15 sessions. The DASH, Constant Merley, and the 36-item short-form survey were used to assess functionality, pain, range of motion, strength, and quality of life. The outcome measures were recorded at baseline, after 6 weeks, and after 12 weeks of therapy. Results showed that adding phonophoresis to standard treatment may lead to significant improvements in patients with shoulder impingement syndrome compared to patients undergoing exercise programs alone. Patients in the phonophoresis group experienced significant decreases in pain and significant increases in range of motion compared to the standard treatment group. The iontophoresis group did not experience any significant improvements in any of the categories. While another study by Perez Marino and colleagues showed that iontophoresis significantly improved DASH and visual analog scale scores, the treatment used dexketoprofen instead. The number of studies published on the use of iontophoresis for shoulder impingement is extremely low. Thus, it is difficult to confirm if the medication affected the results. Future studies can compare the effects of different medications used for iontophoresis on patients with shoulder impingement syndrome. Despite the conflicting conclusion on the effects of iontophoresis, both studies concluded that phonophoresis had a higher significant effect in decreasing pain on patients with shoulder impingement syndrome.
As I was trying to research on the use of iontophoresis for treating patellar tendinopathy, I did not have many results except for this one study that compared wireless versus wired iontophoresis for treating patellar tendinopathy. It was a randomized controlled trial by Justin Rigby and colleagues. It involved 31 subjects, 22 males and 9 females, age 24.5 plus or minus 5.9 years. And the intervention included 6 iontophoresis treatments, 3 times a week for 2 weeks. And there were 3 treatment groups. The subjects were all blinded. The groups are as follows. There was a wired dose controller, which is group 1. Group 2 was the wireless patch. and group 3 was the sham group. And then the outcome measures used were the Kujala anterior knee pain scale, pressure sensitivity, knee extension strength, and a sit-to-stand test.